started. Thank you everyone for joining us today. And I'm going to start with some introduction anyway, so people are coming in, they won't miss much. This is our first program for the Hudson Valley. Really excited to be doing this. As I do note at the end of the program, I guess maybe two housekeeping things, one or three. We'll save some time for Q&A at the end, so please, you're welcome to stay and stay on for Q&A. We're also asking people if they have any feedback, if they're also interested in a specific topic. Again, I'll mention this at the end, but we would love to hear from you, and very excited to get started on something new for us, which is really a specific community-focused insights and discussion of what is going on in nursing homes in the Hudson Valley. A little bit about LTCCC, for those of you who are not familiar, we're a nonpartisan nonprofit organization entirely dedicated to improving care and quality of life for residents in nursing homes and assisted living. Historically, we have always been focused on policy analysis and systems advocacy. We have always done a lot of work with data. I think that's something that has set us apart in many ways over the years. But more and more, I would say over the past dozen years, we've been doing different types of outreach and education to residents and their families, especially long-term care ombudsmen, others who work with residents and families and community leaders. We're also the proud home of two local long-term care ombudsman programs in the Hudson Valley, and our website is nursinghome411.org. All of the resources on our website are available to use and share. They're all free, and the substantive issues that I'll talk about today, those resources will also be available on our website, so no need to take extensive notes or anything like that. I also want to give a shout out to John Rodat, our resident data guru and all around wonderful person and super smart guy. John is has longstanding experience, in New York State and health policy and policies in general, policies in other states and federal policy, but has just a tremendous knowledge of breadth and depth of use of data that have been instrumental for us and really are the backbone of what we're doing today. We've been working with John on this project for, I think, about 2.5 years now, and this is really the first outcome that we're able to share in terms of having some resources that we could share with the community. And we're so happy to be able to share it with you. Quick outline of today's program. So I'm going to do a brief introduction of what this series is going to be about, and then what we're going to be doing with all the programs in this series is essentially it's a 1-hour program split into two. So the first half hour will be a data briefing. It'll focus on the data, what the data are showing. We'll try to highlight some interesting and provide some interesting insights into what is going on in the Hudson Valley. And I see this as being of interest to everyone, including residents and families, long-term care ombudsmen, legislative leaders and representatives and their staff, as well as agency staff in particular. But then also the second half of every hour will focus on residents' rights and really fleshing out and discussing how we can address some of the challenges that we maybe identified in the first half of the program. And this, everyone, of course, is welcome to stay, but this is really going to be geared towards residents, families, long-term care ombudsmen, those who are working and responding to residents and families, maybe in community-based offices, etc. And again, we'll leave time for Q&A. So a brief introduction to what we're doing here and why. Essentially, the need that we have unfortunately identified is, we saw during COVID how catastrophic COVID was, in particular for nursing home residents. And what we've seen in our work here in New York and nationally is that those challenges have persisted, and in some ways even worsened in the post-COVID era. past the public health emergency. I don't want to say we're past COVID. We continue to see really, unfortunately, substandard care, way too much neglect and abuse. So our goals here are to, again, as I was just talking about, engaging the community, helping residents, families, helping legislators and agencies, and those who are working with residents and families, ombudsmen, and other people who advise and help them, helping to support their understanding and helping to give them you all the resources to be as effective as possible in improving care and program integrity. So I talked about our approach before. I'm not going to go ahead. I'm going to pass that by, excuse me. So the first part of our program, the data briefing and insights. A little bit about why the data matter. Nothing is perfect, including data. Data are not perfect. Some people say that you can manipulate data, and I guess, to some extent that is true. We endeavor always to be as conservative and neutral with our use of the data, even though we are a group that is here and exists to support residents and to ensure better care. We try to be, again, we really are very careful about how we use data. And those of you who are familiar with our work, we are, we've been published in peer-reviewed journals, et cetera. We're very committed to ensuring that we use data with as much veracity as possible. And the data are important because they provide an empirical basis for identifying what's going on. We're talking about nursing homes here today, and also, exploring, evaluating, and identifying ways in which we can potentially make improvement. I listed here at the bottom some of the data that the federal government collects and reports. Those include nurse staffing levels, non-nurse staffing levels, staff turnover rates, ownership, citations, fines, and penalties, and then a range of what are called quality indicators, rehospitalization rates, pressure sore rates, rates of residents who are depressed, who lose control of their bowel or bladder, et cetera. So there is a lot of information that is collected. And again, I see my job in these programs is to be reviewing that beforehand and then providing some insights and highlights that I think are most valuable to people who are in or who are serving the Hudson Valley community. I want to move right to the data. Actually, excuse me. Let me just take a step back. Apologies for that. So in the second bullet here, I noted that about staffing in particular, which is going to be the focus of today's program. Study after study over the years has shown that there is a very strong correlation between the levels of nurse staffing and the quality of care. And research has shown prior to and through the COVID pandemic and now beyond, that there's a particularly strong relationship between registered nurse, RN staffing levels, and the quality of care provided in a nursing home. Just very quickly, I think it's worth noting that CNAs, certified nurse aides, provide about 90% of the direct care, the bedside care that residents receive. And they, of course, play an important role. And then there are two different types of what are called professional nursing staff, LPNs or LVNs, licensed practical nurses, and registered nurses. And they all have very important roles to play. The registered nurses, typically speaking, the individual with the highest amount of training and education and expertise in the facility. It's really only the RN, when he or she is in the facility, that is capable of assessing a resident, of managing medications, et cetera. Again, the LPN, the RN, and the CNA all have important roles, but they differ. And as I mentioned a couple of times now, the RN over and over again, we're seeing, even though he or she may not be providing that much direct care, their oversight of the and monitoring of the care provided by CNAs and the LPNs and their training, et cetera, of those staff in their provision of care to residents is incredibly important, as study after study has shown. So as I mentioned, we're going to focus on staffing in today's program since it's so important, and since I thought it was a good way to get this series started. So the first thing that we're looking at today, and this is for the entire Hudson Valley, is the total reported nurse staffing and how that compares to the overall 5-star rating. So as you can see here, and I hope it's clear, tried to clean this up as much as possible. On the left-hand side, you see going up is the reported nurse staffing hours, and then from left to right are the star ratings of facilities from 1 star, 2, 3, 4, and 5 stars. And then you can see the averages here, which is what is highlighted from 3.23 average nursing staff time per resident per day, going up to 5.29 hours per resident day of total nurse staffing time. Again, we're talking about total reported from the facility, total reported nurse staffing time here. And this is totally focused on Hudson Valley nursing homes. And what the data show is that 5-star nursing homes have 64% more nursing staff than 1-star nursing homes in the Hudson Valley. So this gives you some, I think, some real insights into how the nurse staffing has an impact on the quality, because the 5-star rating system from CMS, the Centers for Medicare and Medicaid Services, is not perfect, but it's by far the best rating system we have for nursing homes. And you could see here again how the staffing makes a difference. I would also note that the staffing, you see it creeps up a little bit overall from 1 star to 2 star to 3 star to 4 star. It's really at the 5-star facility level that we see a significant jump in staffing. So that's something to keep in mind, is that the 5-star really does make a difference. 5-star, 4-star is not a guarantee of good care, but you can see what's going on is that below that, we have pretty low staffing. And just to provide a little bit of context for this, there was a federal study done about 24 years ago now that found that nursing homes need to have at least 4.1 hours of nurse staffing time just to meet residents' basic clinical needs, not care with dignity, not good infection control protocols, just to provide basic clinical care. So anything below that is frankly very concerning for us. And I would also mention that in New York State, we have a minimum staffing rule, which we'll talk about a little bit more later on, that requires a minimum of 3.5 hours of nurse staffing time per resident per day. And you could see on, this is average, so there's higher and lower at each star rating, 1 star, 2 star, 3 star, 4 star, and even 5 star. But you can see that the average for 1 and 2 star is below that 3.5. The average of 3 star, 4 star, and 5 star are all above that. Again, lending importance to the idea that facilities should at least be meeting or exceeding that, and that those are falling into these lower categories on average. I wanted to next talk about RNs, and we see a really, really big difference here again with the 5-star facilities. But even I would say if you look from 1 to 2, the 1-star facilities have on average 0.51 hours of RN staff time. Go up to 2-star, it's 0.59. So it's increased, close almost 20%. And then you see going up 3 stars, it's more. 4 stars, it's more. It's about 50%. 4-star facility at 0.74 hours per resident day has about 50% higher on average than a 1-star facility staffing, but it goes way, way up on when it comes to a 5-star. Again, 4 times higher, as I note here in the orange box, 4 times higher RN staffing at a 5-star level, 4 or 5-star level nursing home on average than a 1-star level nursing home on average. So really big differences here. Staffing, as we see, especially RN staffing, really plays out in the quality of nursing home care as indicated by the 5-star rating system. And this is nurse aides. I wanted to show nurse aides as well. And you could see also a slow but steady increase and a overall market difference between the 5-star facilities and the 1-star facilities in the Hudson Valley. So again, this is the reason why I did this. The reason why I show these graphics, is because I want people to see that these are, yes, they're just numbers. We're going to talk more about specific facilities in a moment, but I wanted people to see that for the facilities that are serving our community, these data are showing significant differences in performance based upon staffing, overall nurse staffing, CNA nurse staffing, and RN nurse staffing. I have not included LPN nurse staffing here because there's less data, frankly, indicating that there's a correlation between higher LPN staffing and better care. And it doesn't mean that LPNs are not important and are not making a positive difference in the lives of residents. What it means, frankly, is that too often what we've seen in facilities is that they will overuse LPNs instead of using RPNs. Not all facilities do this, but unfortunately some of them do to save money on their spending on staff. And so as a result, there is, because of that overuse, there are very mixed results when it comes to identifying the extent to which LPNs are making a positive difference. We know that they are. We know that they're on an individual level can be very important, but when they're exploited in certain facilities, that kind of muddies the water in terms of being able to look at the data on LPNs in a meaningful way. So I wanted to give you information. I know that this is a lot, but I wanted to give you, context that I thought was useful. And we'll be in future programs really trying to drill down and providing information that is as useful to you as possible. But I wanted to kind of give a context here, especially when it comes to staffing. So we know staffing matters. Does ownership matter? There's research that has shown that for-profit nursing homes tend to put less money that they receive for care into actual care, that the not-for-profits, the government-owned facilities, more of the money, higher percentage of the money that they get, they actually turn and put into staffing and to other care cost centers. And staffing tends to be the most expensive of the care cost centers. So we want to know, is this true for nursing homes that are serving the Hudson Valley? So again, similar graph, but here we divided it up between for-profit facilities, government-owned facilities, and not-for-profit facilities. And what we found, this is total nurse staffing, we found that as I noted here in orange, for-profit facilities have 24% lower nurse staffing than nonprofit facilities and 36% lower nurse staffing than government-owned facilities on average. So you see pretty significant differences here in where the facilities come. Again, you have outliers here. There are good for-profits and there are bad for-profits. There are good and bad government-owned, and there are good and bad not-for-profits. We're just looking at what's going on, but we're looking very specifically at what's going on in our communities. Registered nurse, again, I'm going to go through the same thing. Total nursing, registered nurse, and certified nurse aides. Here we see a very significant difference. The for-profit facilities have less than half the RN staffing levels of nonprofit facilities in our communities. These, again, are just comprised of facilities that are serving our communities here in the Hudson Valley. And the for-profits have a third of the RN staffing of government-owned. Here we see 0.66, and this is on average, of course, 0.66 average RN staffing in the for-profit, 1.99 average nurse staffing, in the government-owned. So really big differences here about what's going on in our community. And then lastly, the certified nurse aide staffing hours per resident per day. Again, we see very significant differences with government-owned facilities being the highest, followed by nonprofit, followed by for-profit. This is important information and context for you. Again, no reason for anyone to memorize this. The PowerPoint will be available on the website for anyone who wants to utilize this and share it, in their advocacy or in their work. But the important thing to keep in mind is that in New York, we've had a lot of pushback over I would say, especially the last, 10 to 20 years, against government-owned facilities. A lot of counties have sold their facilities, and those county facilities have, play a really important role. And when it's sold to a for-profit, we run the risk of seeing, and we have seen these patterns actually play out. So I think, just in terms of if I was a resident or a family member or working with them and choosing a facility, thinking about, okay, where would I skew my choices? Yes, you want to look at individual facilities. As I said, there's good and bad in every single provider type, but look and see, use this as a context, excuse me, and when looking at facilities. And the same thing, if I am a policymaker, a legislative office, or I'm speaking to my legislative office about the importance of protecting nursing home residents, which we really need more of, again, pushing back, in my view, against this effort to sell, the government-owned nursing homes, excuse me, and to be more conscious and to be working harder to ensure more accountability in the for-profit facilities. So I'm going to do a little exploring of the data. What I wanted to do again is to give kind of an overview and some insights into what is specifically going on in nursing homes in the Hudson Valley. As a general overview in the previous slides, here we're going to dig in a little bit deeper, and then the last part of this part of the program will be providing actual facility level data. So this is just a map of New York State. This is a snapshot of part of the Hudson Valley, and it's color-coded by overall rating. So you could see, the map where the facilities are and how they're rated. Null means that the facility is there's something with their data or their special focus facility, so they may not have a rating here, but the 1, 2, 3, 4, 5 stars are all different colors. Oops, excuse me. Let's just go back there. And then on this slide, this is the same picture, but looking at health inspection ratings. And you can see the pink, which we unfortunately have a lot of here, is 1 star. We don't see a lot of, we see a couple of green, and here's a purple over here. But I'm going to take this to show you actually the data, and hopefully this will open up for me. Maybe we can go here. Okay. So this is the actual map that John has been working on creating for us, showing the Hudson Valley. Let me quickly add for some reason it keeps on pulling out Putnam and Westchester and Rockland. So I'm just going to add those. So we have all of the counties in the Hudson Valley now, as you can see. So this is a map. This is showing the excuse me. This is showing whether they're for-profit, government. Oh, includes. I apologize. Includes for-profit, government, and non-for-profit facilities. And we can see here by scrolling over the facilities what kind of a bit of information. Excuse me. So this is Pine Haven Nursing Home, for example. We include their address, their federal provider number. It's a for-profit facility. It has an affiliation entity name, meaning that it's part of a chain ownership. We can see the number of beds. It has 128 certified beds, 108 average number of residents. Overall star rating is 1. Reported nurse staffing hours per resident per day, as one would expect, is very low, 3.18. Look down here. This is in Rockland, the Northern Metropolitan Residential Healthcare Facility in Muncie. This has a 5-star rating. Its reported nurse staffing hours is higher, 3.83. Not great, frankly, but it is higher. And again, the number of certified beds, the number of residents per day, et cetera. and this number can change. I also want to quickly show our map by measure while we're here. So this is, I just wanted to quickly show, excuse me, the reported RN hours per day, because we've been talking a lot about that. So this is for the community, and you could see it's color coded. Most of them tend to be on the low side. They're the darker red. And so here we have, let's go to a different one. Livingston Hills Nursing and Rehab Center. Their RN hours per resident per day are 0.42. The reported total nurse staffing time per resident per day is only 2.17, which frankly is a red flag for me. And then their occupancy rate, they're for-profit, which is not a surprise, and their occupancy rate is just under 92%. So just some baseline information. Here's the Northeast Center, which is a large facility of course, in the Hudson Valley. And their reported RN hours per resident per day are 0.56, which is, again, on the low side. That federal study I mentioned earlier said that 4.1 hours is really the minimum total nurse staffing time needed to meet resident care needs, and 0.75 of those hours should be performed by a registered nurse. So again, just kind of highlighting how we can show you some of the information that is available to look in, to see what is going on in the facilities in your community. And now, as I said, I wanted to provide some tools that you could take with you and use. So this is just a snapshot of this file. And this file is the total nursing hours per resident day for facilities in the Hudson Valley. I'm trying to make it a little bit bigger. And you can see we can sort it or pick out by county, excuse me. So we have all the counties here. So if I could choose, for instance, if I was interested particularly, and this is on our website, or will be on our website today, I could choose, for instance, Dutchess County and look, and these are the facilities in Dutchess County, and then I could sort them by high to low hours per, low to high hours per resident day. So I can see at the bottom are the Renaissance Rehab in Staatsburg, the Eleanor in Hyde Park, and then higher, having higher levels of staffing, relatively speaking. It's not necessarily great staffing, but relatively speaking, in this community, the Taconic Rehab at Hopewell, Taconic Rehab at Beacon have higher staffing, and these other facilities fall somewhat in the middle. So that's how some of these data can be used. You could also pick more than one county. So if you were choosing a facility, if you were looking at facilities in the county or counties in which you're serving as an ombudsman program, or in which you have constituents as a legislator or a Department of Aging, et cetera, you can look and see what is going on in those facilities. Here I included green, I added green to Dutchess. There's only 2 facilities there. And we have the same thing that we have posted on our website for registered nurses. So this is the registered nurse file, bigger so you can see. And we have the same thing here. So we can look and see, first of course, we can search for individual facility. Here is Pine Haven Home in Philmont. I could see, so I was interested in what's going on in my facility, or if I was interested in just looking at other facilities in Columbia County, I could just select that and see how does Pine Haven stand up. It has, it and the Ghent Rehab are tied for the highest of the 4, the 2 highest of the 4 facilities in Columbia County. So if I was making some choices about where to go, if I was advocating for residents, if I was trying as an ombudsman perhaps, or as a Department of Aging, to look and see, well, where should I maybe, first assign someone to go in and, and see what's going on. I might want to choose Livingston or the Grand because they have significantly lower RN staffing. And of course, this is just a very small sample because there's only 4 facilities in in Columbia County, but you can see, you could use that for any number of these. If you're, for instance, a congressional office, a state senate office, or state assembly person's office, or an ombudsman program, etc. I just want to lastly note that Tolstoy here has no data, which means either there is special focus facility, meaning they've been identified as having persistently serious care issues, or there were other problems with the data that they reported, and that's why that is empty. So those are the two data files that we're sharing today, again, along with today's theme of looking at staffing, understanding the importance of staffing, and providing data and information that I hope will be easy for you to use in the various work that you are doing. Now we're going to move on to the second half of the program. And again, I'll save some time at the end for Q&A. But I want to talk about residents' rights, and in particular regarding sufficient nurse staffing. So a little bit of background. Those of you who have attended our programs before may recall that we'll often start with the nursing reform law. The nursing reform law, it's a federal law, it passed in 1987, and it requires that every nursing home that takes Medicaid and or Medicare money agrees to meet the standards laid out in the law and in its regulations. So this is an affirmative voluntary agreement. Nursing homes do not have to agree to abide by the rules and requirements of the reform law. They do so because they want taxpayer money. They want that Medicare and Medicaid money. And the vast majority of nursing homes in this country do participate, do take in Medicare and Medicaid funds. And therefore, and that includes any nursing home that we're talking about, any nursing home that is overseen by the State Department of Health, and in this context, and nursing homes in which the long-term care ombudsman is visiting. It's really virtually, not all nursing homes, but virtually all nursing homes that in New York and in the United States. So this is really important from my perspective, because nursing homes, again, are not forced to do this. They do this because they want to. They participate. They sign a contract saying we are going to meet these minimum standards. We're going to accept a pretty vulnerable population and care for them within the confines, meeting those obligations in order to be part of the Medicare and Medicaid program. If they do not want to do that, they don't have to. They can run their own facility outside of Medicare and Medicaid. So why is that so important? Because the reform law, nursing reform law, is really robust. And as I note here in the first bullet, it's kind of a mouthful, but it requires that every single resident is provided the care and the quality of life services that they need to attain and maintain their highest practicable physical, emotional, and psychosocial well-being based upon who they are, where they are, and what their goals are. So highest practicable doesn't mean highest practical. Doesn't mean I'm a nursing home owner, I only want to spend $2,000 a day on staffing. So this is the amount of staffing I have. I only want to spend another $1,000 a day on food. This is the amount of food I'm going to give you, and that's it. No, it's based upon the resident. It's based on what are the residents' needs. I've accepted a resident as a nursing home owner operator. I am making the promise that I am going to provide them individualized patient-centered care, and that I am going to ensure that if they have, for instance, they can go to the bathroom with some help, they're going to get that help. They're not going to be put into a diaper because I just haven't paid enough staff to come in to take care of them. I know, and let me say, I have a family member right now in a nursing home who's not getting this level of services, unfortunately. So I know how challenging these problems are. But this is what the whole reason we're talking about it is this is what the law requires. This is what nursing homes have agreed. They're contractually obligated to provide. I would say they're morally obligated to provide, given the trust that we place in them. And so it's all part and parcel of a system in which they have agreed to operate. Importantly, as I note here at the bottom in bold, having sufficient staff with the appropriate competencies to meet the needs of these residents on an individual basis has been required since the beginning. Since the law passed in '87, the rules came out in, I think it was 1991. So this has been a long time. This is not, last year. This is not 2 months ago that there are new rules. Rules change. They evolve a little bit, but essentially these rules have been in place for close to 40 years now. So what's the problem? I mean, we have strong rules, as I've been saying, but we know that far too often nursing home care is demeaning, unsafe. Residents have neglect, they have pressure ulcers, they're diapered or sometimes even double diapered because there's no staff able or willing to provide the care that they need. Why does that happen? And frankly, we've done studies on this, the federal data, which we've been talking about, which are so important. Others have done studies on this showing that far too often, those minimum requirements are just not enforced. And as a result, providers know that they can get away with providing far less care than is required. So what can we do? As I mentioned before, I have a family member right now in a nursing home. She is not getting, by any means, great treatment. Unfortunately, I know that these challenges are formidable. It's hard. It's really hard to change nursing home practices. And that's one reason why we're doing this. It's our first type of program in this way, really focusing on the community and hopefully focusing on everyone in the community, from community leaders to the individuals and the families themselves who are depending upon these services. But I think, to me, what's really important to note is that one, as I note in bold in the middle here, everyone, every single, no matter where they're coming into this, has a opportunity to improve care. And hopefully we can do that if we have the resources that we need to advocate in an effective manner. So I want to talk about some of these standards. Why? Because as I note here in the middle, knowledge is power. Yes, again, these issues are really challenging. I know it personally, and I certainly know it professionally. But if we don't know what our rights are, then we can be sure that they will not be realized. So knowing what the rights are, having knowledge, and having access to resources to share that knowledge and to advocate with it, I think are really important first steps. As I mentioned at the start, I know some people have joined us since, all of the, this PowerPoint will be available on our website, but also we have fact sheets that talk about all the resources I'm going to be going over now. So there's no reason really to worry about taking notes or anything like that, or screenshots. We will be providing this information to you. So one, this is the federal code, nursing services. The facility must have sufficient nursing staff with the appropriate competencies and skill sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident as determined by their resident assessment and individual plans of care, and considering the number, acuity, and diagnoses of the facility's resident population. I know that's a lot, but think of it. One, the third word, must. Not may, not if it feels like it, not if it has enough money left over, must have sufficient staffing. And in order to do these things, again, the resident-centeredness of highest practicable physical, mental, and psychosocial well-being. Not just clinical care, not just keeping people alive, mental and psychosocial well-being, treatment with dignity, the ability and the right that residents have, to have their care explained to them, to understand what is going on, to be treated with dignity no matter where they are, whether they have dementia, whether they're crabby, whether they like to sleep late, etc., that they are treated with dignity. And what I wanted to note here at the bottom, which I have here in orange bold, is considering the number, acuity, and diagnoses of the facility's resident population. Nursing homes aren't warehouses. You just don't take in, not supposed to be taking in people willy-nilly to fill up your beds and fill up your bank accounts without considering that you need to have the staffing and the competencies necessary to meet those residents' needs. So it's really spelled out here. Just a quick note, we have these on our fact sheets. As I mentioned, we have a whole bunch of them that you can use for your knowledge, to share that knowledge, and for assistance with, to help with your advocacy. The 42 CFR, that's the Code of Federal Regulations. I always include that number here in our fact sheets, so people know that we are citing to the federal rules. It's not just something that I made up. It's not my wishful thinking. It's not LTCCC's goals. It is something that comes from the federal rules, and everything in italics comes directly from the federal rules. Sometimes, and we know if we do this, we might lightly edit it just for clarity. But if you see something in italics, it's directly from the federal rules, and you could always go back to the federal rule and find it there. And the second component here, the F tag, this is especially important for people who are in or a loved one of or working with residents in a nursing home, is that F tag it's called an F tag, excuse me, F-725. That is the citation code. So when a facility is cited for a deficiency, for a violation of the minimum care standards, if it's a nursing service violation, it'll be tagged as F-725. And you can see that every nursing home is required to post their deficiency statement in a prominent place, or make it available in a prominent place. It might be by the nurse's station or at the front desk of the facility. You could also find it online on the Department of Health's website and on the federal Medicare.gov website, Care Compare. And you can see there, and that's important. And we include that because if you're a family member, if you're a member of a resident council or family council or ombudsman, you can use that to see what the facility was found to violate, and then have an idea of what they're expected to be doing to make an appropriate correction. So it gives you that really important context when you do see a statement of deficiencies for your facility. Sufficient staff. The facility has to provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis. Nursing homes are not just run from 7 to 3 or during the day. The care is 24 hours a day, 7 days a week, 365 days of the year. And that has to include licensed personnel as well as certified nurse aides. As I note at the bottom, there are some very limited circumstances where the licensed nurse presence for part of the day may be waived, but that's very limited, and you would see that. And then in addition, many states have additional requirements to the federal requirements. State cannot have less requirements. They can't undermine the federal requirements, but they can have more. For instance, New York has now for the past couple of years now, has a minimum staffing ratio, which we'll talk about briefly later on. The federal guidance for RNs, the nursing home has to have a registered nurse serving as a director of nursing on a full-time basis. And that requirement can be met by 2 or more RNs sharing the DON position. I just included that in case there was confusion in specific facilities. I want to talk a bit about nurse aide competency, because this is something, about which I hear a lot. One is having, of course, it's important to have enough staff to provide care, and it's required to have enough staff to provide appropriate care, but also that the care staff are competent, that they're not just there, but they're there and they're able to care for the residents, which the facility has accepted and has made a promise that they can provide safe and appropriate care for those residents. So I won't go through this entirely. Again, we have this this PowerPoint will be on the website, and the fact sheets will be on our website as well. But The facility has to ensure that nurse aides are able to demonstrate competency in skills and techniques necessary to care for residents' needs, excuse me, as identified through resident assessments and described in the plan of care. So it's not just a basic, okay, you're a nurse aide, which, they go through a CNA training and then they're certified, et cetera. It's that the facility has to make sure that the nurse aides are able to care for the needs of the residents, the specific needs of the specific residents in the facility. And then the rest of the language here really just talks about making sure that if someone does not have these abilities, that they're not used on a long time, they're not used on a permanent basis or for a long time. In essence, ensuring that most of the people, if not all the people, in the facility are able to provide that care. If someone comes in on a training, while they're in training, or someone comes in and they're learning the ropes, that within 4 months, they're going to be completely competent. So it's not an excuse that someone is a contract staff. It's not an excuse that someone is, hasn't, learned these things and they're going to learn it next year at the annual training. No, you can have people in who are coming in and are being trained, but you cannot have that for more than 4 months. I just want to note here the CMS statement on competency, which comes directly from the surveyor training. Competency is a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics that an individual needs to perform work roles or occupational functions successfully. This really goes, a CMS surveyors, of course, for those of you who don't know, are the inspectors, the state inspectors. And this is the training, part of their training. So again, over and over again, at every level, making clear that we expect competency. We expect that everyone who is touching the resident in one way or another has the ability to care for them and their needs and their goals in an appropriate way. A little bit about performance review and training of nurse aides. I know we're getting close to the end of the hour, so I'm going to go fairly quickly, but the nursing home has to complete a performance review of every nurse aide at least on an annual basis and provide regular in-service education based upon the outcomes of those reviews. Again, this is not just rote. This is not a factory, a factory line. This is understanding that you have a really important and I would say precious responsibility of caring for individuals when they have a very high level of vulnerability and a very high level of needs. And here again, you see that the expectations are that the facility is not going to just have basic knowledge, not just rote knowledge from someone who came in from the outside or from some training course, that they are knowledgeable about the needs and meeting the needs of the actual residents who the facility has accepted. Just very quickly here at the bottom, this is again from the code. It has to include dementia care training, resident abuse prevention training. It has to address weaknesses that have been identified in the nurse aides performance reviews and in the facility assessment. Facilities are required to conduct ongoing assessments of how they are performing in respect to their residents, et cetera. For nurse aides providing services to individuals with cognitive impairments like dementia, Alzheimer's disease, it also requires addressing the care of cognitively impaired. There's no excuse for a nursing home not to understand how to provide appropriate care and services for residents with dementia, period and full stop. I just wanted to note here, what does CMS, the Federal Centers for Medicare and Medicaid Services, what do they tell state surveyors about reviewing for insufficient and inadequately trained staff? It's a mandatory facility task, meaning that when the surveyors come in, they have to be looking as part of their review while they're in the facility, however many days it is, they should always be looking at, is there sufficient staff? And are those staff adequately trained to meet all the needs of the residents as we have been talking about? I also wanted to note here, it kind of goes under the radar for some people, but since 2003, every nursing home has been required to report the number of nursing staff on duty for each shift. Too often, we see that facilities don't do a great job. They may report, and they may have a posting, I should say, of who they expect to come in for a shift. They may post in advance, even when the people aren't there and don't show up, etc. So there are guidelines now. So this can be useful to you to know when you come to visit, a facility or come to visit a loved one, what is going on the floor. They have to report, who is there, has to be up to date, has to be current, who is there in terms of the RNs, LPNs, and CNAs, and as well as the residents. So you can figure out, okay, what is the what is the ratio? How many RNs are there? How many LPNs and CNAs are there to care for the number of residents in this facility? As I mentioned before, New York State has a staffing rule. The Biden administration promulgated a federal staffing rule last year. To be honest, that staffing rule is now, with the new administration, under attack, so we're not sure how long it will last, but it does require 24/7 registered nurses as of now. Now, let me rephrase it. I'm sorry. So the rule is in effect now. However, the rules is not, even though the rule exists right now, it is not going to be implemented in terms of some of these requirements like 24/7 registered nurses until a couple of years from now. It varies, and we have some information on that on our website. So in other words, the rule exists. The rule probably will be excuse me, the rule will probably not exist for much longer between Congress and the administration. Frankly, we're both hostile to it. However, it does exist. So these requirements are part of federal law. However, the requirement themselves don't call for the registered nurse or for the overall staffing to be implemented until 2 or 3 years from now, depending upon where the facility is located. So I know that's a little confusing, and I apologize, but I just wanted to mention that there is this quantitative rule. And then in New York State, we do have a state rule. It's completely unaffected by anything going on the federal level. It requires 3.5 hours per resident per day of total nurse staffing, including a minimum of 1.1 hours per resident day of professional nurse staffing, either RN and or LPN, and a minimum of 2.2 hours per resident day of CNA time. So you can use those Excel files that I said are available now on our website. You can look up facilities in the community and see what facilities are meeting, in particular, the overall 3.5 and the minimum of 2.2 HBRD of CNA time. So that could be a really important clue for everyone, from residents and families to ombudsmen and other advocates to policymakers and agency staff. What's going on in the facilities in my community, and are they meeting this rule that's been in effect now for 2 years? As I mentioned, this is just a snapshot of one of our guides. They're all available in the Learning Center, one of our fact sheets, excuse me. They're all available in the Learning Center at www.nursinghomefour11.org. Free to use, free to share. I know that ombudsmen have used them. I know family and resident councils have used them. I know that congressional and local legislative offices have shared them. So they're free to use and share, and we welcome you. And also, if you are advocating within a facility, if you're advocating if you're talking to your legislator, they could be useful too, to support that, you have a right to this. The whole point of the nursing home system and the healthcare system is to provide care. It's not just to support a, profit-driven industry. That industry exists for a reason, and this spells out what that reason is. I wanted to quickly just spend a minute, and I'll leave most of this, and it'll be, of course, on the website. But we're hearing a lot, including there was testimony, this week about in New York State about the need for more money. The nursing home industry and their lobbyists always say more money, more money, more money. We need more money. We don't get enough money. We have razor thin margins, etc. And, the fact is that most nursing homes in New York, the large majority are run for profit, and they're seen as great investments. And this is true nationwide, but there is a lot of money in nursing home care. And also, there's virtually no limits on how the operators use that money once they get it. Now, New York does have a minimum spending requirement, but as far as we know, that has not been enforced yet. So what we see, and what we see from the Attorney General's lawsuits, for example, is that some of these nursing homes are taking the money and they're not directing money that is meant for resident care to resident care. Instead, they're siphoning it off into administrative costs. They're paying off other companies that they own, inflated rents, et cetera. And operators do this. They like to have, frankly, as an industry, a narrative that says, "Oh, we don't have enough money. We have razor thin margins, et cetera," because that perpetuates this whole argument and supports their whole argument that they need more money. But in fact, again, most of these places are for profit, and there is a lot of money coming into the system. We have a policy brief, which I think we'll try to update this year on nursing home Medicaid funding. As you can see from the chart here, it continues to go up. On the Medicare side, funding is just incredible. And we have nursing homes that are getting $600, $700, $800, $900, $1,000 more a day, per day, for Medicare rehab residents. The profit margins nationally, according to Medicare Payment Advisory Commission, was 27% in 2022, as that's the last report that came out last year on 2022, found 27% profit margins, and that's what they're admitting to. That's what they're saying. Goodness knows how much money it actually is. I'm going to skip over that for now. And again, just want to leave on a note, as I mentioned before, nursing homes are not warehouses. We've heard for years, decades, even before my time in the 80s, when I look at congressional testimony, nursing homes saying, "Oh, we'd love to hire more staff, we just don't have enough money. We'd love to hire more staff, we just can't find them." Nursing homes have, and we track this, and you could see for your individual facility on our website, the turnover rate. Nursing homes have on average a 50% annual turnover rate. So it's not a matter of hiring staff, it's not a matter of finding staff, it's a matter of keeping the staff. Thanks everyone for joining us today. I have a few minutes. We could stay on a few minutes longer too for Q&A. Our next program will be April 10th at 11 a.m. Email info@ltccc.org if you'd like to suggest a topic for a future program, or if you have any comments, or if you'd like to join our listserv to receive alerts when new materials, et cetera, come out. And thank you to the Dyson Foundation and to the Fields Hall Foundation for supporting these programs. So I know we have some questions in the chat. Oh, thank you, Kay.
Thanks, Richard. Yeah, thanks, Richard. The first question is from Diane. And Diane, if you'd like to come off mute and ask your question live, you're more than welcome. I see you have it.
Hey, Diane,
Sure.
nice to see you.
Hello, how are you?
I'm looking.
I was just asking if there's any advice for constituents who are having challenges getting the appropriate level of care even written into their care plan. This is a new challenge that we've been seeing. Before, we used to see it was written in the care plan and maybe it wasn't being provided, but
Right.
Now we're seeing more of a pushback that somebody says, well, I need this person to walk to the bathroom. Right? They won't even put it in the care plan anymore.
Wow.
And we tried the ombudsman. We're just not quite sure what else to try.
Yeah, I was going to first suggest trying the ombudsman, because they can attend a care plan meeting. They can help them with that. Is it an issue with the assessment? Because the rules require, and actually, let me say that we have fact sheets on resident assessment and care planning, and I know that they have been like the most popular of the fact sheets we have. So there are certainly longstanding issues, around this, Diane. And I can, let me make a note, I can send that to you afterwards. But, and for everyone else, they're on our website, for everyone whose email I don't have. But they lay out what is required to be part of the assessment. And they lay out, and the rules lay out what is, how the care plan has to be based upon the resident assessment. So I remember like years ago when we first put those out, and I would do a program, actually it was in the Hudson Valley area for family members. To me, it was kind of like almost like a 1-2 punch, not to be a pugilist, but it's like you had on one hand, you had to have an assessment, and the assessment has to have, I mean, the rules lay out how robust the assessment has to be. And then the rules say the assessment has to be based upon the care plan. So we have, as I said, we have fact sheets, but we also put together forms for people to use to help guide them when they're actually doing those things, when they're actually experiencing them. So that could help support it. And I would suggest, as I mentioned a couple of times, I know that these are really tough issues. And unfortunately, we're seeing a lot of providers that are just flouting the rules openly, even basic requirements like this.
Well, first of all, they couldn't even get a meeting. So that was the first challenge. They just said, we wrote the care plan. You don't need to be involved.
Wow.
Yeah.
Yeah. That's really troubling. I mean, I certainly think, when people hear from a legislator, especially one that's as powerful as Amy is, if possible, that can make a difference. It could really be an influence. We often tell people, if they're not getting a response from the Department of Health, if they need help beyond what the ombudsman is able to provide, to go to their local legislator, because they are an important voice that people listen to. I would suggest maybe circling back with the ombudsman, because they can actually go to these, they can help to arrange for a meeting that fits the time of the family member or the resident, so it's not just slapdash. And also they can actually participate in that, especially in a place where you're seeing these kind of issues. Teresa, it sounds like you have something. Teresa is our ombudsman director in the northern region of the Hudson Valley, in Region 5. Did you have anything you want to add, Teresa? I don't want to put you on the spot.
No, one of the things that I would say is that if you're saying that they're not allowing the ombudsman to attend the meeting, that is considered willful interference with the ombudsman program. And then that can be elevated in a different way. So I'm not saying we don't have that issue. We do have that issue, where facilities will say, no, we don't want you to attend this meeting. We don't want you to come. But then we elevate that to our state level and we explain to them, and then they get the Department of Health involved. So, because again, that is willful interference.
No, the ombudsman was there. They just wouldn't listen to the ombudsman either.
Okay.
It might also be that maybe it was a volunteer ombudsman, maybe calling and speaking to Judy would be helpful. Judy's the ombudsman director for Region 4. Because sometimes the funding for the ombudsman program is always, an ongoing issue in New York State. But I think as we've been able to give more funding to the ombudsman program, we've seen more professionals, but we still have a high reliance on volunteers. And sometimes the volunteers are great. Sometimes they're just not able to, deal with that at a higher level. So maybe, bringing it to, to the office itself could be helpful too. If I'd be happy to help if. Thanks. Thanks, Simon.
And our next question is from Susan. Susan, if you'd like to come off mute and ask your question live, please feel free.
I have to look back to my question. Well, it was 2 parts actually. I don't know if any of what you've said applies to memory units and assisted living. I don't think it did.
Yeah, it does. I mean, nursing homes have memory care units too, but this is all only for nursing homes. Yeah, unfortunately.
Okay, then
I'm sorry.
it's irrelevant.
Yeah, sorry about that, Susan.
And just one more, it looks more like a comment from Margaret. It says, would love to see program and rules and regulations in assisted living and see staffing and other issues. I believe they're less regulated than nursing homes, and yes, they are. No federal regulations there.
Yeah, and as a result, we don't really have a lot of data and information on what goes on in assisted living. It's an important issue for us. We do have obviously resources. We've been pushing for more, and advocating for better standards, but it's unfortunately we don't have as much information to do this kind of work, data-driven work in assisted living.
One more question that just came in from Kay. It says, in regards to resident rights, is a home able to limit family visits and cell phone use? There's an ongoing issue of residents' family being iced out of their care.
Well, all the rights in the nursing homes go to the resident. So if the resident wants to have company, they can have company 24/7. The only restriction on that a facility can impose is if it disrupts other people. So you can't come in at 3 a.m. and have a party, because that would be disruptive to most of the other residents. It is a congregate setting, of course, but it is the resident's home, and that's how the federal rules view it. So you can't have visitors, and of course you're allowed to have a phone. It's your phone. Again, the only restrictions that could be put in place are those that relate to respecting other residents and the comfort and privacy of other residents in the facility. We should probably end here, I think, because it's 12:08. Thank you so much for joining us. Again, if you have any suggestions as to topics you'd like covered, etc., we'd definitely welcome them. I wish I could do more in assisted living in this manner, but unfortunately, we can't. We do other advocacy around assisted living, but it's just not as data driven, unfortunately. Thank you. Thanks everyone for joining us. Thanks, Ellie. Bye.